Hi, everybody.
Hi, everyone. Thank you for joining us this week. I know we had a little bit of a computer difficulty last week. I hope everybody got the link. If not, afterwards, we'll send the recorded webinar as well. Today, we want to focus on hospital-acquired infection. I'm Dr. V.
Hi, Dr. Horn. So, hospital-acquired infections, I don't think we've done this topic before. I think it's a very good topic. Or if we have, it's been a while, right?
Yes.
I'm not sure when the last time was that we discussed this specifically, but, it's something that all the hospitals worry about. And, how to address different hospital-acquired infections is, a really good topic to talk about.
And I know we all worry about part about quality metrics during commission, CMS. So some we'll share our experience and some thoughts. So just wanted to initially start off with things that we could acquire in the hospital as employees and others. So needle stick exposure and safe disposal of practices. So just wanted to kind of recap, as healthcare workers, some of us are vaccinated for hepatitis B, and that's one of the biggest reasons that we get vaccinated. Transmission risk is 30% for hepatitis B. If you get vaccinated, if you have antibody, chances of you getting the infection is extremely low. But if you're not vaccinated, chances of you getting the infection is 30%, very scary. Hep C, it's about 7% from bloodborne transmission. Thankfully, though, in the last 10 years, we have medication. We now have cure for Hep C, but 7%. And HIV, everybody really worries about HIV, but the chances of it's still something to worry about. But the transmission risk is about 0.3 to 0.4%, so lower than Hep B and Hep C.
And everybody should be vaccinated for hepatitis B. Hepatitis C doesn't have a vaccination. There is no vaccine for hepatitis C. Um, and, when we talk about needle stick injuries, let's see, one of the things that we'll talk about is, so it's after the needle went into the patient and then comes out, and then a person sticks themselves with a needle. Hospitals really should have a protocol, and it's a good idea to make sure your protocol is up to date of what to do in those situations. And it's good for the emergency room physicians and everything to have that protocol and what to do in those cases because the regimens and the recommendations do change over time. I'm not sure the last time it changed, but it was within the last few years, I think, of what medications to give for HIV.
We'll share that soon in the next slide as well. But yes, definitely, occupational, employee health, infection prevention, and everybody working together. Having the testing regimens and the treatment regimen is very important. Of course, if you do have an exposure,
Yeah, if there is an exposure, it's good to call occupational health and discuss with them and discuss exactly what the exposure was, whether it was a needle stick or and what the conditions was, what happened at the time. Because sometimes, patients will come in and they'll say, they sat on someone's couch and they got a needle stick, or, there's a worker that put his hand into a drawer and then got a needle stick. And is the, and it's, you know, when the patient comes in, that's the patient. And then, so if the nurse stuck her finger, that's going to be the patient. Sometimes it can get a little confusing because that's the patient. And then if there's, the person that the nurse was working with, so if they were drawing blood from somebody, it gets a little confusing because the nurse is drawing blood from a patient, but if she sticks herself, then we're discussing as if she is the patient. But sometimes, so if the the needle, I'm not sure exactly how you discuss it, but when the needle goes into, like, if a nurse is working with a patient and if that person that they're drawing blood from has a recent HIV test or hepatitis C or hepatitis B, if they don't have an HIV test, then you would do a rapid HIV test.
yeah. So like that's when like the occupational health in your hospital system, employee health needs to get
Yep.
involved because always everybody has to have a process of how do our employees report?
Yep.
And then once they report, how do you get if the from the person who our employees got exposed, how do you then now collect blood samples? And, a lot of times you have to have permission from the person they got exposed if you could do Hep B, Hep C, and rapid HIV. If you're able to do that, that is really helpful for your employee. And then you could decide, do you need to give HIV medicine or not? But if you're not able to do that, then there's a different discussion that we need to have as well. Usually, in my personal experience, when my employees have had exposure, the person that they got exposed, we were been able to do the testing very rapidly.
Yeah, so if a rapid HIV test is done on the patient that had the blood draw originally, if a rapid HIV test is done and it's negative, you know, that would really help with, what to do with your patient. If you do it and it's positive, then for sure you'd want to be giving antiviral medications, anti-HIV medications, and you'd want to start it immediately.
Yeah, and lastly, one other thing to remember is if you expose the patient to your blood too, it's vice versa. So it's always important to talk to the patient about that too. And again, I think this is every hospital should have, healthcare facility needs to have a policy and protocol for this.
And so if I got stuck with a needle, one of the things that would happen is also they would do a rapid HIV test on me because they want to see, did the person have HIV before, or is this going to be a new conversion? So you can show a negative test at the start, and then you want to test them again, whether that's in a couple weeks or, it kind of depends on the situation and what your protocols are to see if they went positive. But you'd want to start uh, antiretroviral medications immediately, and then and you want to make sure that you start them pretty quickly. The faster
Yeah.
you start, the better.
So, a quick review though, again, for Hep C, the biggest causes of patients who get Hep C, sources of transmission from persons with acute Hep C is like injection drug users, if you have multiple sexual partners, sexual contact with Hep C positive, surgical procedures, and occupational exposure. So again, I just wanted to point out surgical procedure and occupational exposure, acquiring Hep C is about 28% nationally. That's a big number. So that's why it's important for us to kind of pay attention to that and making sure we test everybody and have a protocol. And next slide. So once you are exposed to someone and then you're going to be starting them on, now you're thinking about, let's say the patient lets you test them rapid HIV test and they come back positive, or the patient refuses, now you have to tell your employee, well, they might be high risk, we don't know. So it's better for you to start treatment for HIV. The recommended HIV drugs, Truvada, which is the commercial name, it has two different things combined, tenofovir and emtricitabine, plus an integrase inhibitor, right, raltegravir or dolutegravir. So you need to start this medicine within 2 hours after, ideally within 2 hours of exposure. So this is why it's really important our healthcare facility coordinate, have some supply on hand, because you never know if your employee can get this medicine after hours on the weekend. And then being able to replace the pills, when you get supply back. So having a small amount of supply in the ED or in your hospital system is really important. And then also giving the prescription, because a lot of times insurance will pay for it, but you need to make sure if you give a prescription, the pharmacy that your employee goes to is able to give that medicine immediately. Sometimes we have gone into challenges where our employees cannot get the medicine immediately. So that's why it's sometimes also important for you all to have like a small amount of supply that you could replenish, like 2 days worth of supply while they get their medicine refilled. So I kind of wanted to highlight that. And then Dr. Horn.
Oh yeah, no, and these medications, every few years, like I said, they change. So if your protocol hasn't been updated in the last, few years or so, even if it has, it might be good to look at it, make sure that you have the most up-to-date recommendations as far as what to start, because some of these medications change every so often.
Yeah, and biggest complaint we get is nausea. So that's
Yeah.
important to tell your employees, our healthcare workers, avoid retransmission. So, safe sex and blood donation. Very careful in the first 6 months. Testing for drug toxicity is really important. 4 weeks after starting, because Truvada, tenofovir component sometimes can cause renal creatinine to go up. And then, of course, continue checking your HIV testing, 4 weeks after, immediately 4 weeks, 3 months, 6 months after exposure to make sure you didn't acquire HIV. And sometimes people ask, why do you have to give HIV medicine so quickly? And the reason is when you get exposed to HIV, the virus circulates in the blood and then then it goes into your lymph nodes, the lymph reservoir. You want to eliminate it before it can get into the reservoirs where it could continue to replicate. So giving immediate medicine to get the viral, if you are exposed, under control and killed off.
Yeah, the goal is to stop replication as soon as possible and then stop it from setting up those reservoirs. Yeah, and really it works very well. And if there's any question if a patient's in the emergency room or if they stick themselves, it's okay to start HIV medications.
Yes.
People tolerate them very well. It's better to start them and then after further discussions, in the next few days, if you decide that maybe the risk wasn't that high, because sometimes when people get stuck, the emotions are high for good reason because it's a big concern. But it's better if there's a question to start, and then later, if you decide that the risk wasn't that high, or you can always discuss it later. But if it isn't started in the first 72 hours or so,
Yeah.
then the recommendation is going to be not to start anything. So
Yeah.
it's better to start.
Yeah, so that's why it's really important.
Yeah.
Like, be vigilant, have good policy, start drug as soon as possible, have some drug in your system, some supply after hours, weekend if your employee cannot get the drugs, and you could replenish the supply. And the drug makers can actually give you free supply if you get on the program, and they could supply that as well.
So, question. General surgery physician was helping suturing of a large wound. She accidentally pokes herself. She immediately reports the incident to employee health department. The source patient is found to have HIV. Which of the following is correct? So,
love anybody to type it in or unmute and let us know which one do you think is correct.
so in these cases, and it's here it's a general surgery physician. It seems like a lot of people get needle sticks and things in the middle of the night, so it's good to have an up-to-date protocol, so you're not looking for one at 2 in the morning, or you're not kind of scrambling in the last
Any
minute.
takers in the chat? A is immediate treatment, wait a month. Chances of acquiring HIV is 30%, or patient can donate blood. Okay, yeah, we got answers. Thank you.
We
Yes,
have
immediate. Yeah.
Yes, so you'd want to start immediately, so you don't want to wait. Wait a month. So after waiting a couple days, the chance to start is gone. Chance of acquiring HIV, I think it's more like 3%.
It's point. It's
or point,
0.3%.
0.3%.
Yeah, so it's very low. Yeah.
Yes, 0.3% for HIV. And then patient can donate blood after 3 months. Now you'd want to wait longer and recheck.
Yeah. So we just really want to cover that. Now we'll get into our bread and butter, healthcare acquired infections too.
So we have central line related bloodstream infections, CLABSI, catheter associated urinary tract infections, CAUTI, ventilator associated pneumonia, VAP, surgical site infections. And so these are some of the things that we're going to discuss. And we're going to start just talking about the significance of hospital acquired infections.
Yeah. I wanted to kind of show you all right hand and left hand, like data that come out over and over again, how much money it costs to have a CLABSI. So if you have a CLABSI, a line-associated bloodstream infection, 2007 data said hospital, it cost about 7 to 29,000. Recent data, I think this was from 2013, 45 to 65,000. CAUTI, about 14K to recent data on this study, 800. I don't believe that's how low it is. Surgical site infection, 15,000 to 20,000. So it cost us a lot of money every time we have a hospital acquired infection. A case of C. diff infection in the hospital is about ten to $15,000. So we know it costs hospital money, but also it's bad outcome for our patients. And also our outcomes are reported on publicly and safety. So it's, who will come to our hospital depends on these quality indicators. So what are some of the tools and where can we go from here? So could prevention of healthcare and associated infection increase hospital costs? The financial impact of healthcare associated infection from hospital management perspective. So in this study, it was a large study. What they saw was the most common method of calculating financial impact. The hospital, every time you prevented an infection, hospital saved about 137,000 in cost savings by prevention overall. So hospital and healthcare facility was suffered drastically, increasing the cost prevention acquired healthcare acquired infection. Therefore, hospital costs and could be reduced by reducing HAI, which makes sense. I just want to show that number. It's huge amount of dollars overall that we can prevent for our healthcare facilities.
And then central line infections. So when we're talking about a central line, here's a picture of a cartoon guy with a central line. We're talking about lines that go centrally. So where there are no valves, because the veins have valves, but if you put it centrally where there are no valves, you can give medications that essentially won't be stuck in the veins and can circulate really well. So central lines, PICC line, peripherally inserted central catheters, umbilical catheters, tunnel catheters. So here are some pictures of some. Now, they're
That looks bad.
yeah, you don't want to have that redness there. You don't want to have pus there.
Yeah.
Now, you can have infections that are in the soft tissue as well, and on the skin, and it can kind of form an abscess there. Or you can just have it in the blood. So bacteremia, bloodstream infections. So, and they really, when we look at why do they happen, putting in a line like this makes it essentially gives you a risk for having an infection there. And then also the type of patient that has the line in. So frequently, kidney and, dialysis patients, if they have a dialysis line, whether it's like this, where it's a tunneled line, are at risk for infections. But patients with central lines, sometimes they have it for chemotherapy, sometimes they have it for antibiotics. Those patients are going to be high risk for getting infections.
Yeah, lots of reasons, but we do have some tools, and I hope everybody's using the tools. So when you insert the central line, it's going to be so important. We do it on maximal sterile barrier. Hand hygiene, ChloraPrep, iodine is not good. So we should be doing ChloraPrep, sterile gown, gloves, face protection, hat, large drapes. Remove it as soon as possible. And, a central line care. It's really important to do central line care and documenting central line care on a daily basis. How does the line look? How does the dressing look? I'm not a spokesperson for different type of products.
Yeah, ChloraPrep is chlorhexidine.
Chlorhexidine, exactly. And one other thing that I really like is that I don't know if you all heard about BioPatch or CHG impregnated dressing. In my experience, I really like the CHG impregnated dressing because it lays right on top. BioPatch moves around. So having a CHG impregnated dressing on top of the line really helps create a sterile area. So if you all don't do that, those type of tools, extra tools would be really helpful. But auditing the line daily and making sure everything is appropriate is also very important.
Yeah, and if they do have a patch, sometimes it's good if you can easily look under it to make sure there isn't any redness or pus or anything there. But
The problem with the patch is it moves around and it never
yeah.
on top of the line out to the skin. But CHA impregnated clear dressing is really nicely. You could put it on top. So either way, some sort of extra protection is really helpful.
And one more thing on central lines, uh, if you're suspecting a line infection, blood cultures would be a good idea.
But one thing I want to caution about the blood culture, do not draw it from the line. So every time you draw blood culture from the line, you're going to break barrier. So if you look at, even if the line is clean, it's sitting on your skin, so you're going to have a lot of biofilm. So if you start pulling blood from the line, you're going to now get coag negative staph, and now you don't know if it's real or not. So anytime you want to do a blood culture, if they're ill, it's better to do it peripherally. And get two set of blood cultures, so full bottles, aerobic, anaerobic, two set of cultures peripherally, and in a very sterile fashion. And you could also use this device that like ciphers off the first 1 ml. Some of the commercial name is Curin. Again, not a spokesperson for that device, but that helps eliminate, decreases the contamination rate. Something like that is so much better, but really be careful of drawing blood culture from ports and lines because you're going to break the barrier and contaminate the culture.
Yeah, and with central lines, usually the first question from my standpoint is, do they need the central line? So
Mhm.
if they don't need it anymore and it's easy to remove, then that would be a good plan. If it's something like a dialysis catheter and they need it, then we'd ask, what are they growing? If they're growing Staph aureus or Pseudomonas or a fungus, then you would definitely need to have that removed and have a line holiday while you give systemic antibiotics. And so if they can perhaps do dialysis and then remove it, and then we'll see how many days they can go without the line. So, if they get dialysis 3 times a week, they may need it, in a couple days. But really, if they're in the hospital, if the uh, kidney doctor, if the nephrologist can look at their labs and see, and they might say, oh, they don't need it yet, and they could check the labs the next day, they don't need it yet. So it's kind of a spectrum. I like the longer they can be without a line, the better. And then when a line needs to go in, when they need dialysis again, they can place the line and then restart dialysis. But that whole time, if they've been on antibiotics, the longer they have it out, the better.
Agree. And here's some appropriate reuse consideration for Foley catheters as well. One of the things I always hear is you need strict isonos, and that's not a thing for Foley catheters.
Yeah.
You could weigh your diaper, you could put external catheters for, male and female. So really, strict isonos is not a need for Foley catheter in other settings. Critically ill patient, you might need that, but on the floors and stuff, there's other ways of measuring urine. Acute bladder obstruction, selected surgical procedure sometimes that you'll need it. Sometimes you need assistant or sacral wound, perineal wound, because you don't want a contamination, but now you could do a lot of external catheters again. End of life care, sometimes comfort measures, or chronic indwelling Foley. And if you really need somebody to have chronic indwelling Foley, really consider, can you do a suprapubic catheter versus a regular Foley catheter? Suprapubic catheters, less infection, and much better than having a Foley catheter because it really traumatizes your urethra. So these are some considerations.
And then when to get a urine culture. So
Discourage.
yeah, when to get one and when not to get one. So um, frequently, I was talking about one of my first questions with other situations. My first question, if a person gets a urine culture or they say something is growing in culture, I'll say, well, why was the culture done in the first place, or what was the indication? Because I want to see, do they have an infection or not? Here, the urine quantity, color, smell, sediments, turbidity. So any of these things are not a reason to get a culture or not a reason to suspect infection, really. So if they say my urine's darker color or it smells bad or there's some sediment in it, then those aren't things that I would give antibiotics for.
About 8 years ago, one of the hospitals I was practicing in, we were culturing for everything, color, smell, sediment, turbidity. And we really change urine culture only if it's really needed when you have symptoms. And only we will send, the lab will reflex the culture if you have white cells more than 10, if you really needed it. So we decrease urine culture by 12% in a large health system. So it's really important not to like working with your lab, working with your team, not to culture for like smell. A lot of times when we're rounding, our nursing staff sometimes will say, it looks bad, it smells bad. I'm like, how is a urine supposed to smell? You know?
Yeah.
So it's really important not culturing things unnecessarily.
So if you have protocols in your hospital system that will reflex to culture for any of these reasons, you can, review that and see if that can be removed.
Mm-hmm.
So, if you order a UA with reflex to culture, the criteria to culture should be looked at to see are those things that would actually reflect an infection, or are they something like this where, the urine may smell bad, but it doesn't mean that there's an infection, doesn't mean they need antibiotics or to reflex to culture. So if you can decrease the number of cultures in your system, that would help everybody. It's expensive to do the cultures, and then the patient will get unneeded antibiotics. Even if they have bacteria in their UA, if they don't have any symptoms, symptoms being frequency, urgency, oh, excuse me, frequency, urgency, dysuria, then you wouldn't have to worry about culturing it. You wouldn't have to worry about treating them.
Yeah.
So
And then also make sure we're not screening urine culture just because they're getting admitted.
yeah,
Just because they're going to have a hip surgery, you don't need urine culture. Only time you need a urine culture for screening is if you're pregnant. Pregnant women, they should not have asymptomatic bacteria. If you're doing an invasive urological procedure, you need a urine culture to treat prior to surgery. So you know what bug and you could give it 60 minutes before the procedure. But you do not need a urine culture for like heart surgery, lung surgery, hip surgery. Nothing else ever needs a urine culture. Sometimes what we notice is pan culturing. Somebody comes in with pneumonia and you clearly know it's pneumonia and you have this practice of like blood culture and urine culture when their urine is, they have no complaints in the urine. So it's really important, like not pan culturing and being very mindful because now you're going to get unnecessary information that you didn't need and you're going to chase after that.
and we talked to one health or one hospital that they would do urine cultures on everybody so they could show that it was present on admission. I wouldn't recommend doing that. I would
Yeah.
recommend not getting cultures unless they have frequency, urgency, dysuria, unless they have symptoms.
Because if you start screening on everybody and people are going to be asymptomatically like colonized and you're going to give ton of antibiotics and then they're going to get C. diff.
Yes, yeah, I was just going to mention that.
Yeah.
So we get people that have C. diff, and we'll look back on why did they get antibiotics in the first place, and sometimes they got it for asymptomatic bacteria, and it's really unfortunate to see those patients with C. diff that they didn't need the antibiotics in the first place. Yeah. And the next one is reduced ventilator-associated pneumonia. So bundles work, and with bundles, sometimes it's not clear what part of the bundle is maybe the best part or doing the heavy lifting, but the bundles really work if you do everything in the bundle. So head of bed elevated above 30 degrees. So you want the bed kind of up so they're not aspirating. Oral care every hour. Sedation vacation, meaning if you can wake them up, each morning so they don't get too deep into their sedation. Sometimes people will get very sedated, and then that takes them a long time to wake up. So having them kind of wake up, a sedation vacation is recommended. Peptic ulcer prophylaxis and DVT prophylaxis.
All these are really important. Just remember oral care. There's some new data that came out, I believe, from Shea last year. A lot of places we were doing oral care with CHG oral care. Data shows that using CHG actually increases mortality in patient.
Hmm.
So it's a lot of places that now have gone back to doing oral care with toothpaste or mouthwash. So just if you're still doing CHG oral care, there's some data that's discouraging that use, so just be aware. And surgical site infection. One of the most common infections in the hospital is surgical site infections. There's proven method to preventing surgical site infection. Antibiotic prophylaxis is very important. Hope you all have protocols. We're happy to help, but it's really important you give the right antibiotic for the right procedure. So if you're doing a chest surgery, giving cefazolin versus if you're doing belly surgery, giving belly antibiotic coverage, cefazolin plus flagyl or something like that. It's really important you give the right antibiotic within 30 to 60 minutes before cut. So you cannot be pushing antibiotic. Sometimes we have seen like patients will be rolling into the OR and they're pushing the cefazolin and they're going to cut patient right now. You need to give at least 30 to 60 minutes for the systemic antibiotic concentration for it to be effective. Surgical prophylaxis can be discontinued 24 hours after you treat this steroid prophylaxis, so you don't need it for days and days and days. Prior to surgery, CHG bathing has shown to be effective in patients. So, a lot of places give patients to take CHG wipes, baths. Those are really important. Don't clip the patient's hair in the OR. Do it outside. Anytime you clip in the OR, you're creating a lot of like micro aerosolization. That's increased risk for infection. So doing it outside the OR is really important. Don't shave, clip. Shaving causes microabrasion, puts at increased risk for infection. Nomothermia and glucose control is very important. DVT prophylaxis and beta blockers. So these are some proven methods. Some of the new things that I have noticed is like, interesting data in Nebraska. We had really bad surgical site infection rates and hysterectomy infection rates. But in the last year, we have done much better. As a state, we all got together, do a gap analysis, bringing awareness. So it's really important to like evaluate your procedures and policies in each of your facilities for these procedures and what you all are doing. And here's a paper on diagnostic stewardship. We are really good at antibiotic stewardship, but diagnostic stewardship is how can you use labs in a proper way for infection prevention and partnership with that infection preventionist at the hospital and healthcare setting. Really nice paper. If you all want to read this, you can. So lots of data that shows CDC through National Health Safety Network monitoring greater than 70% of all U.S. hospitals for all these HAIs. And they say, coming up with a good plan is important, but having diagnostic stewardship on the next page, sorry, is really important too. Examples require only positive C. diff for foam stools. Is not necessary. Unformed stools after hospital day 4. How do you catch these things earlier? Not testing everybody for C. diff if they don't have symptoms. Just really like thinking before we do ordering. So next slide, please. So in December 2019, the Division of CDC hosted a meeting to discuss patient safety through diagnostic stewardship. Diagnostic stewardship include ordering the right test for the right patient at the right time to provide the right treatment. This is from CDC. Correctly diagnosing CLABSIs, CODIs, and C. diffs, for example. So again, like we were talking about causing unnecessary contamination in the blood culture or unnecessary urine culture and getting a call CODI. So how do we do a good job only getting cultures when it's really needed?
Yeah, and it sounds like it's both for diagnosing it correctly to when they have it to say that they have it, and then when they don't have it to say that they don't have it. Yeah, so that if you're able to say that they don't have a CODI or a CLABSI, that you shouldn't be reporting things that you when they don't have it.
Yeah, unfortunately, if you send a culture and even it'll get called, so we have to be careful.
Yeah.
So for a diagnostic stewardship team, you really need a multidisciplinary approach. Just like antimicrobial stewardship, it needs to be led by our infection prevention team core people are the infection preventionists at each of the healthcare facilities. They're fantastic. They know what's going on. An infectious disease physician, if there's somebody, or another physician, quality leader. Of course, on the broader team, you need to have lots of collaboration, right? The CNO, CMO, nursing educator, hospital physicians, EVS leaders. It's a group effort. And also ad hoc team as you figure out what is the issue. Are we not doing central line auditing? How do we do that better? Is lab drawing blood cultures incorrectly without using Curin? How do we work with lab? So it's really important to have an active functioning team for infection prevention diagnostic stewardship. When orders are placed during work hours, so some of the steps, some of the hospitals we work in, we have some procedures. So we have our attack team where the IP and the ID doctors, we work together. And when orders are placed unnecessarily, it gets escalated. It starts with the bedside nurse, goes to our infection preventionist, goes to the ID physician, and then how do we really dive into each case and really evaluate if it's really needed or not needed. One of the hospital, I am on call 24/7, 365 days. Thankfully, my partners cover me when I'm on vacation. We noticed ICU had the highest rates of blood culture and urine culture ordering, and lots of contamination and unnecessary ordering because they were pan culturing. So when that happens, it gets escalated. Usually the bedside nurse is able to stop when it's deemed not necessary. We have a checklist process. If it's still needed, goes to infection preventionist. If it's still needed, it escalates to me. I review, then I call the bedside provider. We discuss the case. Sometimes it's needed. I tell them, please get the blood culture peripherally, use Curin, urine, is it a chronic folate? Can we change out the folate, get a clean sample? Just really walking them through lots of different steps has shown really to be successful. Next slide, please. So again, infection preventionists lead the initiative, whatever the initiative is. Isolation compliance, hand hygiene, C. diff orders, daily device monitoring. We every day we get a device list of C. diff orders, all the lines in place. We review it, and sometimes we spot some C. diff orders that are inappropriate. So even before it goes to lab, we stop, because it'll be like Bristol stool 3. You don't need to order C. diff; it's foam stool. So really having a 506. Sorry. Really having a multidisciplinary approach is important, and our team approach is important. We'll show you some data. So one of the hospital, Dr. Horn and I work with for our, we had, as you see, we had higher C. diff infection in 2019. So as you said, 15,000, let's say, per C. diff, and it was 36 infections. So we worked on really a checklist process. Do you really need the C. diff testing? We went to 2 testing process in the lab, and as you could see, it went down to 14. I mean, you could never eliminate it completely, but we have overall slowly been able to bring it down to actual real infection versus like false infections that were coming in the community and overdiagnosis. We have something called a code D. So, and what we were noticing is that patients were coming in with diarrhea, but we were not testing them until late. So it was getting called hospital acquired. Meanwhile, they were sitting in the hospital for 3 days, spreading all the infection everywhere to other patients. That was an opportunity we noticed. So we started a process called Code D. So the nursing staff at bedside will, if there's a diarrhea, they'll escalate it and get it checked within that first 3 days to make sure we're not missing C. diff infection. So we could decrease a hospital-acquired infection, but also isolate and treat the patient faster. And then, yeah, this is the Code D process, the first 3 days. And then if you go to the next slide. this is a process where it doesn't go into the permanent chart. If the nursing staff notice the patient having Bristol stool 6 or 7 when they get admitted, they're worried about uncontrolled diarrhea. They place them in contact isolation, enteric. We say don't use hand sanitizer, soap and water sign, bleach for cleaning. We inform the EVS, and then we talk to our bedside provider, and they order GI pathogen and C. diff screening. And then this happens within the first 3 days when a patient comes in if they're having diarrhea. And the next slide, let's say somebody starts having diarrhea after 3 days of being here. So then you want to know, is it really C. diff or is it something else? So we always make sure, is it Bristol stool 6 or 7? We make sure, do you have less than 3 stools? If it is, then it's not really C. diff, because C. diff, you have like 10 stool a day. Laxatives given, really going through this toolkit. And if they say no, we say no to the test. If they say yes, okay to do the test, or it get escalated. Next slide, please. Here's another for CARDI prevention. There's a checklist again. If you really need urine culture, and if it's really needed, then they go through the checklist. And, fever, suprapubic tenderness, abdominal pain, CVS tenderness. And then we say, stop, don't order culture for cloudy, foul smelling, sedimentation, pan culturing. And if it's really needed, then it gets escalated. Our IP team knows, and then it gets ordered. And then as you could see our data, it has come down nicely over the last 4 years. And then for CLABSI prevention, again, we have a toolkit. I'll show you. We'll kind of hurry. We have 3 more minutes. If you go to the next slide. So here's the next slide. During COVID, we had a surge of CLABSIs. We really worked hard, and you could see the impact of not having CLABSIs, bringing down to 0.24 SIR rate. That is incredible. So if you go, here's our checklist again, making sure, does the patient have a central line? Does the patient have a port? Understanding the need for, blood cultures, then understanding if they do really need the need for blood cultures, telling them collected by peripherally, use the Curin device to make sure that we waste the first 1 ml to decrease contamination, and we approve the testing. And really discouraging ordering from central lines if you could get blood culture peripherally.
Oh, yeah. And the thing with also with central lines, sometimes when it gets removed, the central line, they'll cut the tip and they'll have the tip sent for culture. So I try not to do that as much as possible, because sometimes if you already have something in the blood, then you already know the answer.
Yeah.
So if they have Staph aureus in the blood,
there's
there's no reason to do further cultures on the line that's removed.
CDC actually discourages not to do that. So we should not be doing that.
And sometimes when it's removed, you'll get coag negative staph. So if they have Staph aureus in the blood, it doesn't need to get done. And when you remove it, it might grow coag negative staph, and then people get confused and they say, should we also cover for this? And I just recommend not doing it. And the surgeons will sometimes say, oh no, it's no problem, I'll do it for you. And I say, no, please don't. And they'll, no, it's no problem. But it's really because you don't want to grow things, and you don't want to identify things you don't need to identify.
Just quick summary on diagnostic infection prevention stewardship, diagnostic stewardship. It's a team sport, so get all the team members together. IP and infection prevention physicians should be leading this effort with quality, and everybody working together. Can reduce unnecessary orders, reduce unnecessary antibiotic, create collaborative culture, increase patient safety outcomes. And just like I just showed you data, real life data, you can make an impact on the infection rate. We will stop there and ask for questions. Any questions that we could answer? Any concerns? Happy to answer any questions or concerns. If not, we will send out the slides. Thank you for the attendance, and we will all see you all next month again.
Yep. Thank you, everybody.
The recording's done.